Um, this this session is live streamed on Facebook, and if for some reason the slides were to go down and your camera is up, I just want you to know you will be on Facebook. If your camera is off and the slides are down, nobody will see your name or anything like that. So just want to let you know. I want to also welcome the people who are watching from Facebook. Please, if you have any questions for either here or on Facebook, if you have questions, put them in the chat box or in the comment sections on Facebook, and I promise I will get these questions asked for you. So excited to have you here. We're going to get started, and I'm going to turn this over to Dr. Ann Genovese.
Hi, good evening. Thanks for joining. Brief introduction of myself first. My name is Dr. Genovese. I'm a child and adolescent psychiatrist. I work at the University of Kansas Health System in Kansas City, Kansas. And I've been a child psychiatrist now for going on 20 years. So hopefully lots of experience that I can share with you. This talk is clinically focused. I have no disclosures. I don't get paid an honorarium by any companies, anything like that, to provide this information. And this information, to my knowledge, is accurate as of today's date, January 12th, 2023. So if somebody's watching this recording at a later date, of course, there may be updated information which is available. So my plan is to give plenty of time during the presentation or at the end for questions. So I expect people may have some specific questions that we can go to, because this is quite a broad topic to overview. So let's get started. Our objectives: we want to learn about medications that are prescribed to children and adolescents who have developmental, behavioral, or psychiatric disorders. Understand that medications can help with target symptoms and in ages for which they are not FDA approved. So we're going to mention off-label prescribing quite a bit in this talk. Be aware of some of the reasons for treatment avoidance amongst children, adolescents, and families. Consider the potential risks and benefits of treatment options compared to the risks of opting out of these treatments. And briefly review at the end the SAMHSA, Substance Abuse and Mental Health Administration, SBIRT approach for adolescent substance misuse, and we'll explain what that is when we get to that slide. All right. So 1 in 5 children have an emotional or behavioral disorder. Many kids don't receive treatment. And so we want to change that statistic if at all possible, help as many kids as we can. Benefits of treatment can be life-saving in some instances. In most instances, improve the quality of life, improve social, emotional well-being of the child, school performance, etc., reduce the risk for negative outcomes. And these negative outcomes on the slide listed, just a few that came to the top of my head were violence, school failure, substance abuse, homelessness, incarceration, suicide. So bad things happen when kids don't get treated for behavioral and emotional disorders. All right. So treatment options. This talk is going to focus on medication therapy, and I just wanted to make the point that medication is only one of the many treatment services that a child with a mental health condition can receive. There's also psychotherapy, which can be individual, family, or group, and it should always be part of the treatment plan for a young person with a serious mental disorder. Especially case management or community support services are designed to meet the needs of the child in the home, school, and community, and sometimes higher levels of care when necessary, which could include intensive outpatient programs, residential treatment, or psychiatric hospitalization can become part of the treatment plan. So getting to the topic that we wanted to cover specifically with this talk, psychiatric medications. We're going to cover some common psychiatric medications, their indications and uses, symptoms that they manage, potential side effects, avoidance of medications, some of the reasons why, and addressing substance abuse. So there are many psychiatric medication classes, and that's kind of how this talk is organized, and also guided by the diagnostic evaluation, which is always first before we start talking about any kind of medication treatment. The diagnosis guides our medication selection. So there's ADHD medications as a class. There are antidepressants, anti-anxiety medications, mood stabilizers, antipsychotics, and sedatives and sleep agents. Also, increasingly, treatment for addictions in adolescents, although not widely utilized. And we're not going to go into that in detail, but just wanted to briefly touch on the importance of addressing addictions. I just thought that kind of specialized information might be beyond the scope of what we're trying to relay in this talk. So, okay, starting with ADHD. Just quickly, there are 3 key features of ADHD: distractibility, hyperactivity, impulsivity. So you may or may not have the hyperactivity in order to have a diagnosis of attention deficit disorder, or everybody goes under the same umbrella now of ADHD, whether or not they have hyperactivity, because the syndrome, the core feature is the distractibility. It's the third feature, the impulsivity, however, that causes the most trouble for the child often. So featuring a book here, Dr. Russell Barkley, a psychologist, just to remind everyone that behavioral interventions for ADHD are also very important. Dr. Barkley, as a world-renowned expert in ADHD, sees ADHD as a disorder of self-regulation, and that dysregulation impacts both emotional and behavioral self-control. So a big part of the reason for treating ADHD is to help the child to get more self-control, to be able to think before they act. It's not simply for improving school performance, as some people might assume. And so disclaimer, there may be some brand names which are left off of this list of ADHD medications. The point is there are an awful lot of medications to choose from. And mainly, though, they're divided into the 2 classes of methylphenidate and amphetamine type stimulant medication. So we're starting with, I should have titled the slide, stimulant medications for the treatment of ADHD. There are also non-stimulants, which are going to be covered on the next slide. So stimulant medications, the brand names are either immediate release or time release, lots of different time release mechanisms. There's liquid preparations. There are dissolvable tablets. There are chewable tablets. There are liquid patch preparations. At the end of the list on the methylphenidate is one that you take in the evening, and it has a delayed onset, so it doesn't start releasing until 8 hours later. And so all different kinds of nuances that differentiate these choices from one another. For the most part, methylphenidate is a good stimulant to start with. If we're going to choose a stimulant for the treatment of ADHD, stimulants are still considered first line treatment for ADHD due to the superior effectiveness and tolerability. On the average, for most kids with ADHD, they're going to do better with stimulants. They're going to tolerate them better. And so lots of advantages, and also more years of experience and data to support their safety and effectiveness. So, and again, I don't want to read every brand name. These are brand names, and in subsequent slides, I always try to include the generics, but basically they're brand names of either methylphenidate or either amphetamine type stimulant, which can be mixed amphetamine salts, or dextroamphetamine, which is a variation of the same molecule.
Can I ask you a quick question on this, Dr. Genovese?
Yes.
If you'll go back to that one. So my son is ADHD along with a few other things, but so he takes methylphenidate, but is it prescribed as Ritalin? And then like, so every single one of these brand names, if they're given just a generic methylphenidate?
So it's a methylphenidate is the immediate release generic formulation, which we used to call Ritalin. It
Okay.
has about a 4-hour duration in the immediate release. And
Mhm.
so it used to be administered and still can be administered, just not so often anymore. Most people prefer the time release for convenience. And sometimes the time release reduces side effects. But yeah, the Ritalin is morning, noon, and 4 p.m. if you need an all-day duration type of a thing. So when you go to the other brand names, those are all time release preparations.
But
And
they're all generic
they're,
methylphenidate.
yes, the generic
Okay.
ingredient. Yes, good point. So the medication inside that time release capsule is still methylphenidate.
Okay, because I know he tried a gazillion different. I mean, the Adderall, the Vyvanse, the Concerta, all of these things have been tried before with him, and they didn't work, so they went to Ritalin. So now I was just really confused when I saw all of them under the same thing. So thank you.
Yes, and sometimes the old school immediate release preparations do work better. And so just because they're new and more convenient doesn't mean they're better. And so sometimes we do a little backtracking to to the original compound if we make the mistake of not starting with the original compound in those kids for whom that would have been the best choice, like it was for your son, it turns out. But yes, there is sometimes a bit of trial and error finding the best fit. Okay, so ADHD is a very common disorder. 7 to 8% of kids meet criteria for this diagnosis. Stimulants, by the way, just to mention, are Schedule II narcotics, so they are controlled substances. Medications for ADHD are definitely more effective than behavioral methods. So behavioral interventions are very important, and that's why I was mentioning Dr. Barkley. Um, so, but by themselves are not significantly beneficial, particularly on head-to-head trials. Medications far exceed the benefit of behavioral interventions for ADHD. This is not true for things like anxiety disorders. For anxiety disorders, you know, psychotherapy is more effective than medication, but in ADHD, medications are the most effective intervention. So I already mentioned that stimulants are first line. Combination treatments may be preferred in some cases. And so more than one medication in combination sometimes is used to treat ADHD. And long-term outcomes for children treated for ADHD are vastly superior in many respects compared to those not treated. So when considering whether or not uh, a person would want their child to take medication, they have to consider the outcomes that are typical for children who are untreated. And so there are studies that go back. Typically, those are historical comparator trials because it's no longer considered ethical to randomly assign children to the non-treatment arm of that type of an experiment because we know that they will probably suffer in the long run. So I wish I had more time. If it was just an ADHD lecture, I would go down the list of all the different ways in which treatment for ADHD can help improve outcomes, say 5, 10 years down the road and possibly throughout the life because you're laying a groundwork of, you know, success, hopefully, or a treatment that helps support success if everything else is in place to support that success along with this treatment. But it can make a huge difference for this child in their life going forward. So just a few guidelines for stimulant medications. We mentioned there are a lot of preparations to choose from, lots of factors that affect your choice of medication, and side effects we have to consider, of course, and they're listed on this slide. lots of potential side effects. Most kids do just fine. If they have mild side effects, they get used to the medication. We call it tolerance. They develop tolerance, and the side effects generally diminish with time. Sometimes they do, sometimes they don't. We do see sometimes, and especially our kiddos on the autism spectrum, will see a greater likelihood of side effects actually with stimulants compared to typically developing peers. And also younger children are more prone to side effects. So if a younger child has side effects and the decision is we're not going to try another stimulant because that was just, the child was too irritable, too stressed out, too emotional, we might wait a year or two and then try again. So that's just something to be aware of. Drug interactions, mostly so some medications can affect the metabolism of other medications, of course, and so we need to be aware of that possibility. But also caffeine and energy drinks, those are stimulants, and so we have to caution people about combining stimulant medications with caffeinated beverages. And then toxicity, usually only with high doses. Although some people are just very sensitive to these medications, and I've seen visual hallucinations in just a handful of kids over the years. So it's rare, but it can happen. And of course, we have to check the blood pressure, the heart rate, family history of cardiac issues makes us be particularly careful about prescribing stimulant medications. All
Dr.
right.
Genovese, there was a
Yes.
question in the chat.
Yes.
For an autistic plus ADHD child with a family history of both schizophrenia and bipolar, is there a reason for clinicians to be more cautious about prescribing stimulants?
So anybody with a family history of especially the schizophrenia, so it's a young child, and it's very rare for children to be demonstrating the onset of major mental illness until about the age of puberty generally. There's nothing about the family history of bipolar disorder which would cause you to avoid a stimulant. As a matter of fact, adults with bipolar disorder can take stimulants for their ADHD as long as their bipolar disorder is stabilized first. If the child is demonstrating anything that suggests they might be vulnerable to that, the development of schizophrenia, you have to be really cautious in that situation because you're increasing dopamine levels in the brain. And so our antipsychotics, which treat and manage the symptoms of schizophrenia, the mechanism of action is to reduce dopamine. So like we're doing exactly the opposite of what we should be doing with brain chemistry when we're using stimulants, if what you're trying to do is control, prevent, or reduce psychosis or the risk of developing psychosis. So there's not a lot of evidence that this would increase the risk of going on later in life to develop schizophrenia. So I wouldn't avoid the effective treatment in that situation. All right, so moving on to non-stimulants. Non-stimulants are not controlled substances, so they're a little bit more convenient to prescribe. And so primary care doctors are more comfortable prescribing them in many cases for that reason. They get a little uncomfortable with controlled substances. And so they're sometimes given in combination with stimulant medication. So the two brand names, Intunib and Capve, are brand names for guanfacine and clonidine. They're considered alpha agonists. They were used for the treatment of high blood pressure in adults before they became FDA approved in these time-release preparations for ADHD. So only in the time-release preparation are they actually FDA approved for ADHD. But again, immediate release preparations in some cases can be more effective and certainly can be as effective, but may have more side effects. The immediate release preparations are less expensive. So sometimes a consideration too, particularly if you're paying out of pocket or if you have a large deductible on your health plan. So those old generic short acting twice or sometimes 3 times a day meds are preferable for other reasons sometimes. Side effects: dizziness, drowsiness, lowering of blood pressure can occur. And then Strattera generic is atomoxetine. It is dosed according to the child's weight, more tolerability issues, and you have to titrate more gradually for that reason, but can be just as effective as the stimulant medications in many cases. So, and again, just lots of possible side effects to watch for. So that's on the ADHD meds. Now we're moving on to antidepressants and anti-anxiety medications. So I lump these two together because the same meds in many cases can treat either depression or anxiety. So all those depressive disorders, major depression, persistent depressive disorder, um, late luteal phase dysphoric disorder, which is considered a mood disorder, used to be called PMS, can be treated with serotonin reuptake inhibitors as well. And so we have the two classes, the selective serotonin reuptake inhibitors we call SSRIs, and serotonin norepinephrine reuptake inhibitors we call SNRIs. All righty. And SSRIs have actually the most evidence in children and adolescents. So those are the ones we usually start with. I have a list of commonly prescribed SSRIs and SNRIs on the next slide for your reference. So, but SNRIs should definitely be considered when SSRIs are either not effective or not tolerated. Most antidepressants are also beneficial in managing anxiety. Depression or anxiety can cause irritability. So if we have an irritable child, we have to think about the possibility of these underlying conditions possibly contributing to that irritability. The goal is to treat to remission of symptoms if possible. A lot of times we treat until the symptoms improve, but ideally we should persist and treat until symptoms remit or until that child is back to baseline as much as possible. Especially with depression, with mood disorders. If we're not in remission, if we don't feel like our normal selves again, we're at risk of having a relapse, and we want to avoid that. We mentioned using meds in combination with ADHD. Well, the same is true in this case, especially with depression. Augmentation can help when one medication alone is not sufficient. And psychotherapy should always be encouraged. So I mentioned psychotherapy is more effective in many cases than medication in anxiety disorders. Certainly psychotherapy should be first line and medication second line, but for major depression, you actually want to encourage both because the most effective treatment in that case with serious depression would be your antidepressant plus your psychotherapy. Psychotherapy reduces the risk for suicidal behavior. And also depression is not only biologically based, but there's a huge psychological component in most cases as well. So the treatment needs to include psychotherapy. The reality is sometimes people don't want to do that and they just want to take medication. And it's like, if that's what they're willing to do, then that's okay, but we'll still encourage psychotherapy as a component of the treatment. So I promised the SSRIs and the SNRIs. So here is the list. We've got, again, we may be leaving out one or two, but these are the most commonly prescribed, some of the newer agents. So I've got brand names listed in blue and then the generic name in black in parentheses following. And there are a lot to choose from. So Prozac was the original SSRI. It was a game changer. I was just starting to practice when Prozac was FDA approved. And all of a sudden we have antidepressants that are not only effective, but well tolerated. So in the past, the only antidepressants we had was at the far lower right screen is Elavil, amitriptyline. That's a tricyclic antidepressant. That's an old antidepressant. Those are the meds we had before the SSRIs and SNRIs became available. And at antidepressant dosages, those medications just caused a lot of side effects, a lot of sedation, a lot of sleepiness, dry mouth, constipation. People just hated the side effects and often wouldn't take the treatment because of that. And so kind of defeats the purpose. We still use Elavil, but usually in low doses. for different things. Repetitive behaviors in autism, there's some thought it might be helpful there. It can be helpful for stimulating the appetite for somebody who is not eating. It can be helpful for lots of different things. So, but the point is we're usually using low doses for other indications and not necessarily for depression or anxiety disorders. But the rest of these, everything else on the list, are commonly prescribed for depression and anxiety disorders. Side effects, lots of possible side effects from antidepressants, but like I mentioned, these newer, we call them new generation antidepressants, much fewer in the way of side effects to be concerned with. Rarely we do have serious side effects like agitation. Sometimes with the SSRIs, you can see activation, or the patient can experience that as anxiety. If there is vulnerability for bipolar disorder, then you can definitely trigger a manic episode or serious mood changes. Suicidal thoughts or behaviors can occur with antidepressants. It's rare, and generally we think it's related to the underlying depression, but I've seen it in a handful of cases where, you know, the individual never had any suicidal thoughts and all of a sudden started experiencing those when they started treatment. It could be a coincidence. Treatment is not always effective, and the underlying depression can worsen before it gets better, especially if the treatment is not effective. So there's lots of different possibilities for suicidal thoughts or behaviors to occur in the midst of treatment. Often people are not being completely honest initially with suicidal thoughts. They're afraid they're going to be hospitalized or forced to accept treatment that they don't want, or they don't want to worry their parents or loved ones, so they won't disclose. And then later they trust us more and they start talking about suicidal thoughts. It may have been there all along, actually. So that's also a possibility. So that suicidal behavior warning is on all prescription medications that have an FDA indication for treating depression. So a lot of anticonvulsants that are FDA approved for bipolar depression have the same warning label on them. So I think there's an acne medication too. Accutane has that same warning. Lots of medications have that warning label on it now. So the FDA just, if anybody in those clinical trials all of a sudden reports suicidal thoughts in the midst of the clinical trial, there's a good chance it's going to be listed as a potential side effect for that medication. So that's kind of the way some of that works. But moving on to other anxiolytics, so anti-anxiety treatments that are not SSRIs or SNRIs. And these, aside from buspirone, which is the first medication listed, everything on the right-hand side, those are all benzodiazepines. And so in the old days, that's all we had for treatment of anxiety, other than the tricyclic antidepressants, which I'd mentioned previously. And so those are habit forming medicines, those are sedatives. So we don't prescribe those to kids for the most part. We will once in a while give a low dose just for maybe, you know, we have a blood draw coming up and the child is terrified of needles, and maybe a low dose of lorazepam. That's a typo on Ativan. The generic name is lorazepam. Xanax is alprazolam. Okay, sorry about that. But one of those two meds actually in low dose, maybe right before they go to the dentist, if they're terrified of, you know, going to the dentist or getting a blood draw or something like that. Or kids who are having panic attacks and won't step into the school building in the morning, maybe a low dose of benzodiazepine just for a short term until we can kind of get them past the hump, get them past that phobia, which is preventing them from being able to do something so important as going to school in the morning. So those medications are still used sometimes and can be helpful, but we don't want to prescribe them on a regular basis. They're habit forming. And then on the left side of the screen, buspirone is strictly for anxiety. And that's the only indication it has. It's in adults actually, but it can be helpful in kids as well. And then you can use these other medications off label for the treatment of anxiety. Various antidepressants we already mentioned. Antihistamines sometimes help a little bit with anxiety. Hydroxyzine is a good example of an antihistamine that people take as needed for anxiety or sometimes on a schedule basis. Antipsychotics we should not prescribe for the management of anxiety because of all of the potential side effects, which we'll cover here on a slide coming up. But in reality, people will tell us some of these antipsychotics have a very calming effect and people like them. And it's like, but they have all these potential side effects. We try to use those short term and get away from them if at all possible, unless we have a diagnosis like was mentioned before, schizophrenia, where antipsychotics are definitely indicated for the treatment of that condition. I mean, and no question on that, but and also supplements sometimes can, and I'm blanking on some of the valerian root comes to mind. Some of the supplements can be helpful for anxiety. Okay.
I'm sorry, we did have a question on Facebook.
Uh-huh.
Which antidepressants do you recommend or see best for kids with autism?
So there is a leader in ACAP, and she favors citalopram as an SSRI in autism. Now, I don't know if there is much evidence to suggest that that particular antidepressant is better than any others, because each child is different. And so generally speaking, clinicians will start with something that's FDA approved. So the two antidepressants FDA approved for children and adolescents for the treatment of major depressive disorder are Prozac, the generic is fluoxetine, and Lexapro, the generic is escitalopram. So unless, let's say mom had major depression and she'd tried a bunch of antidepressants and nothing worked until she found sertraline, which is generic for Zoloft, then we might start with Zoloft because mom already, we share some pharmacogenomic, differences. The way we metabolize medication is shared between family members, and so that might predict that the child may have the same experience. They may be more likely to respond to that particular antidepressant. So really, that's a more important factor than just the diagnosis of autism. Does that guide us to a particular antidepressant? Not necessarily, if that helps. Kids on the autism spectrum a little more likely to experience that activation, that restlessness, hyperactivity that we sometimes see with antidepressants, which can also include insomnia and agitation. And so maybe some of the more activating antidepressants like Prozac or fluoxetine, if we do choose to start with one of those, we'll start with a lower dose and maybe increase more gradually, be a little more cautious proceeding with that. Good question. All right, so mood disorders or mood stabilizers. Mood stabilizers are indicated for mood disorders like bipolar disorder, mania. Mood stabilizers can be used in depression when there's a lot of irritability or what people might refer to as mood swings. Mixed states when they're experiencing symptoms of all of the above, more or less. Mood stabilizers are not habit forming. They provide a good calming effect. They can be used off label for the management of aggression. Some are used for the treatment of seizure disorders, migraines, or weight management. And lithium in particular can reduce suicidality. So if somebody has strong suicidal tendencies, lithium can be a particularly good choice as a mood stabilizer or as a medication you'd augment to your antidepressant. We mentioned before, augmentation of the antidepressant is sometimes done. So lithium augmentation to reduce the risk for recurrent suicidal behavior, and somebody with that history might be a good choice. So the commonly prescribed mood stabilizers, starting with lithium, under a couple different brand names. Here I listed the generic name first and the brand name second, just because we almost always just refer to lithium as lithium, whether it's in one of these time release brand name preparations or not. And then the rest of the meds on that list are actually all anti-seizure medicines. Depakote, Lamictal, Tegretol, Trileptal, Topamax, and Neurontin. Neurontin probably not as much benefit actually compared to the others, but can be helpful sometimes in seizures, and it's really well tolerated. So, and it helps with certain kinds of pain syndromes. So if there's some other condition that they have where Neurontin may end up being, or gabapentin is the generic name, might end up being beneficial, then it may help somewhat with mood and certainly can help with anxiety. It can have a calming effect. and is just very safe and has very few side effects, and no blood monitoring required, which is nice. Okay, so lots of potential side effects to mood stabilizers. And some of these listed are specific just to certain mood stabilizers. So I didn't want to make a separate slide for each, but you'd want to look at the particular medication and the list of frequent side effects for that medication, and not one of these slides that covers side effects that can occur from many different mood stabilizers. So that was just a quick overview of mood stabilizers. Psychosis. So we're going to talk about antipsychotic medications next. But just wanted to mention that symptoms can include confusion, which can wax and wane, get better and worse over time, impaired reality testing, and or the auditory and visual hallucinations can be associated with mood disorder, including depression. So somebody can have major depression with psychotic features. Bipolar disorder can have psychotic features, or major mental illnesses like schizophrenia or schizoaffective disorder. Schizophrenia is now being seen on a spectrum as well. So psychosis doesn't necessarily indicate a mental illness. So if somebody's having psychotic symptoms, particularly if it's new onset, it may be related to a medical condition, may be related to delirium, which is an acute confusional state. And then you have to look for what's causing that, and treat the underlying medical condition, which is causing the acute confusional state that happens to be associated with psychosis. And it can be related to drug toxicity, whether those are legal medications or illicit drugs. So that's always when you have symptoms of psychosis, consideration. All right, so antipsychotic medications, lots of choices. Thorazine's the original antipsychotic, still around. We still use it, not as much. And we'll cover the two that are FDA approved for irritability and autism here coming up. But some of these are better choices because they tend not to be associated with as much weight gain. They tend to be like just safer from the standpoint of a metabolic syndrome that can be associated with antipsychotics, where they can affect your lipid profile, cause increases in triglycerides, or increase the risk for heart disease, or impact the cardiac rhythm. Lots of potential side effects with antipsychotics. We use them sparingly, and we want to have good justification when we do use antipsychotics. So here's a list of more common and less common, fairly rare side effects. But when we're getting our informed consent, we should be covering most of these, because they've been known to occur. Seizures, which is the very last rare side effect, actually, I don't know if I should have that under rare. Maybe I should move that over to, because in autism, so kids with autism have an elevated risk for developing seizure disorders. It's about a fourth of kids. A group I work with, we've published on that. Should we be screening kids with autism for abnormal EEGs to see if they're prone to developing seizures, so that we don't give them an antipsychotic that then triggers a seizure? And maybe we could have known that if we would have seen the abnormal brain activity on the EEG, which is a very simple procedure. But anyway, our neurology colleagues don't agree that screening EEGs makes a whole lot of sense. So that's not being done. We just are going to be more cautious about seizures because we know of the elevated risk. The risk in autism is at a young age, and once again around the age of puberty. So I've had some adolescents and even young adults with autism have their first ever seizure or grand mal seizure type episode. And antipsychotics can increase the risk of triggering that. So that's why we're even more careful with those meds. All right. So moving on to autism in particular, wanted to mention, the concept of neurodiversity. Autistic differences do not need to be remedied, or I don't know if reformed was a good word. I came up with this at the last minute this afternoon, and I'm not sure that sounds right. But in other words, we want to make sure that we recognize that neurological differences are to be recognized and respected as any other form of human variation. And it was actually Judy Singer. She was an autistic sociologist, and she coined that term in 1998. And it's just amazing that 25 years later, people are finally, I don't know, the word is really getting out finally. I feel like just these past few years. So but there are some very real challenges and serious challenges associated with autism for some kiddos, and irritability would be one. And the symptoms of irritability associated with autism, and it's listed on the leaflet of the medication. It's FDA approved for irritability, which includes aggression, deliberate self-injurious behaviors, temper tantrums when they're extreme, and quickly changing moods. Um, and then the other target symptom that some kids could benefit from at least consideration of treatment options would be repetitive behavior. Sometimes the repetitive behaviors are really severe and interfering, and even can involve self-injury, so stereotypical behaviors. And so we're trying to find more effective treatments for that one, and we're not very far along with that, but there are some clinical trials underway as we speak, trying to find better treatments for that. So there are only 2 medications actually FDA approved for anything associated with autism, and that would be for irritability, and that's risperidone, generic for Risperdal, and aripiprazole, generic for Abilify. Other medications can be helpful. Um, Other antipsychotic medications can be just as helpful as the 2 that are FDA approved. And so when we don't limit ourselves just to those 2, but we might start with one of those 2 because they have been around for a long time and have that evidence to support their safety and efficacy in this population. Guanfacine and clonidine, I mentioned those are ADHD meds. They can help specifically with irritability and autism. You don't have to have a diagnosis of ADHD in order to try those medications. Um, Anticonvulsants, same thing. Though some of those mood stabilizers we've mentioned. Buspirone, which was an anti-anxiety medication. And then a supplement called NAC. And NAC apparently is no longer available over the counter. I know our pharmacy here at the hospital can compound N-acetylcysteine for patients who want to try it. So it's an off-label treatment. It's a supplement, and it can be purchased, I guess, at health food stores. But like I say, I think it's been pulled off the market. I don't know if the manufacturers stopped making it, but um, and I've had lots and lots of parents try it. I don't know that I've had very many who have been very impressed with the benefit, but it, it, it has some evidence in the literature. So sleep agents, hypnotics include melatonin. Benadryl can be helpful for some people. That's what's usually in the Tylenol PM products that you buy over the counter for sleep aids. I mentioned the hydroxyzine for anxiety. It can also be helpful for sleep. Um, Trazodone, which is an antidepressant. We usually only prescribe it for sleep these days at the higher doses. It causes too much sedation. The antidepressant doses are too high. People don't usually tolerate those. So we just give a low dose, helps you sleep, and is not habit forming, and is not a sedative or tranquilizer. So has those advantages. Clonidine, same thing. Amitriptyline. That doxepin is another one of those old tricyclic antidepressants that we use at low dose, and in this instance for sleep. It's been FDA approved under, I forget the brand name, it got FDA approved for the treatment of insomnia. And then Ambien, and there's another one that I haven't, Sonesta, I think it's called, but I haven't seen it prescribed in ages. I haven't seen Ambien prescribed in a long time either, come to think of it. But cognitive behavioral therapy and relaxation strategies can also be very effective for sleep and should also be utilized. So medications aren't the only thing that can help with sleep. Lots of literature on sleep hygiene and things you can do to improve the quality of your sleep as well. I talk to kids about it all day, every day. I feel like, you've got to stop taking those naps if you want to sleep well at night. Get up about the same time every day, avoid the caffeine past noon, etc. Get off the screen an hour before bedtime. So lots of things that can help with sleep. All right. So I think an important topic to cover is why kids don't take their medications. It happens a lot, and I feel like it's a constant battle. And so I'll just cover some of the reasons. Stigma, kids are very self-conscious. They care what other people think. And if there's another child who might find out they're taking medication and tease them about it, that's a reason they might not want to take medications. They find it to be a hassle, especially if they get a stomach upset, if they take the pill on an empty stomach, they find it to be a huge hassle to have to eat a little something in the morning before they take their medication. Sometimes, some kids. Lack of education about the disorder or the treatment could be a reason they don't want to take medication. Fears, that the medication could be harmful. The fact of not having transportation, which makes going to the pharmacy and the doctor's offices for the appointments to get the prescription, it makes everything more difficult. So they're less likely to be receiving treatment. The taste of the medication is a common complaint. The child who can't swallow pills, getting confused about the dosing, and they'll just quit taking the medication if they not sure how they're supposed to take it and it's not entirely clear. So I try to be real clear when I explain how to take medications. They just simply say they can't remember, they forget, that they might be having side effects, and then cost is a big reason why they might not be taking their medication. So they might be getting pressured from family or friends. The child simply says, nope, don't want to. So the child just oppositional about, a lot of different things, maybe, including, why don't you take this medication? It can help. We mentioned teasing, negative media reports. So if they've come across something that they saw on a video or whatever, or they're using some other kind of either a supplement or drugs, and then you prescribe a medication that has an interaction somehow or a combined effect that's unpleasant, and they may choose not to take the prescription.
Dr. Genovese, we have another question in the box, but I do have to say, I feel like I could be a pharmacy sometimes for methylphenidate because my son, though he's 27 years old and he's got it on his phone, he chooses or forgets to take it all the time. So, but there is a comment or a question in the chat box. Is there an objective way to distinguish temper tantrum from autism meltdown? Terminology often affects how teachers, caregivers interpret and respond to overwhelmed, frustrated behaviors.
Good point. Yes, because I think there's a lot of judgment that goes along with that temper tantrum term, and I don't like the temper tantrum term. Sometimes I feel like it's very descriptive, but it implies that it's intentional or it's just behavioral. Um, and so uh, meltdown is a much better word, much less likely to leave a teacher. And, teachers really should receive more education about developmental disabilities, including autism, ADHD, learning disorders, etc., Tourette's. I mean, because so many kids have these developmental disabilities, I feel like the knowledge and training they have is so minimal. And so, yes, often that first knee-jerk response is, the child is just acting out, that it's just a volitional behavior. They're just being difficult, stubborn, whatever. And
They can come to our childcare trainings that we're doing for childcare providers now.
yes.
Because that's what they're learning all about,
Yes,
so.
yes. So I hope that answers that. So helping the teacher and the school team to reframe and to hopefully understand, what's underlying the meltdown, what might be the trigger, what's causing this. I have a young man I've been treating for years, and just for anxiety, he's on the autism spectrum, and now he's 19, and he's in that transition, the
18 to
post high
21
school.
program.
Yes, the post high school program. And for the first time ever, he's becoming aggressive. So he's having
Hmm.
he gets aggressive, and then he has the meltdowns when they try to, restrain him, of course. But
Yeah.
we realized the trigger was probably because all of a sudden, for the first time, he's not in a self-contained classroom. He's having tons of transitions. He's going to his job training, and and his days are not, he
Right.
doesn't know what to expect from one day to the next. And so
Mhm.
lots of transitions, and that seems to be the trigger. So identifying the trigger and helping them to be more aware um,
I
of.
will also say, sadly, in Kansas, there's a huge lack of special education teachers. So yeah, unfortunately, we're asking the regular ed teachers to do more and learn all about these disabilities as well. But it would help with red flags too and earlier identification if they did.
It
But
absolutely would. So I'm about to wrap up, um, and just wanted to touch on the issue of substance abuse, drug misuse, abuse, addiction, and self-medicating. And so, self-medicating might be where things start with substances. Um, and this slide is referring to nicotine and marijuana as some of the substances that our children and teenagers often use and abuse and self-medicate with. And so that's just one possible path toward addiction or chemical dependence, we used to call it, and now we call it substance use disorders. Um, People worry about it potential for addiction to prescribed medications, and actually it's usually the street drugs or medications obtained via illicit means. So the kids, it's not the prescriptions we're prescribing to them that are being supervised in doctor's visits and the parents are administering and monitoring. It's if they're abusing prescription drugs, they're usually obtaining those on the street or stealing them out of somebody's medicine cabinet and that kind of thing. But if there is a prescription drug involved in an addiction, of course, opioids are the most addicting prescription medications, and that's not part of what we do in psychiatry. We don't manage people's pain. Opioids are for the management of pain syndromes. Um, Benzodiazepines or sedatives, we mentioned that we sometimes use those short term, and it's because chronic administration on a daily basis can lead to dependence. And so we do see sometimes drug abuse involving those benzodiazepine sedatives. Stimulant medications, very rarely have I seen a case of abuse with stimulant medications, particularly in any kids we've treated. When they're taking them as prescribed, our kids typically do not want to take their medications except they see that they help. And so that's why but it's just very rare. It could occur, but the time release reduces the possibility of feeling any kind of a high or a stimulant effect. If the person says, "Oh, I take my medicine, I feel so much more wide awake and full of energy," and it's like, "Oh, it's probably too high of a dose." You don't need as much to focus as you would to feel ramped up or hyped up, and that's not the goal. And usually, if that's happening, you're also experiencing some negative effects. You're probably feeling agitated as well, and at risk of having other side effects that we wish to avoid. So these are low doses and time release generally. So very low risk of addiction. I just want to make a big point of that because they are Schedule II narcotics according to the DEA. Um, and in fact, in the context of ADHD, talking about stimulant medications, kids who are treated for ADHD have a lower risk for developing substance use disorders as adolescents and adults when their ADHD is properly treated. It's just one of those things that I mentioned before. There's lots of things that treatment helps with, and this is one. Kids with ADHD have an elevated risk for developing addictions, but the successful treatment of their ADHD reduces the risk that they will become addicts. So, prescribing the stimulant does not increase the risk of addiction, we mentioned. Diversion or trading or selling of ADHD medicines can occur. It's more known to occur on college campuses. It is a felony criminal act, so maybe that helps reduce the possibility that somebody would think about doing that. And we do educate, especially our kiddos who are in that age range. Stimulants are sometimes shared to help peers cram for exams or something like that, or to lose weight. And in the kids, very rare. In adults, maybe more so. And they're not FDA approved for that. They're only FDA approved for ADHD. So in the long run, they haven't been shown to be that helpful with weight management. And so you have to be aware, and when you're talking about the risk of diversion, that some stimulant preparations can be crushed or snorted or injected. And then that's where your drug abuse for individuals. The individuals abusing stimulants are usually getting those stimulants through illicit means. They're stealing them. They're not usually being prescribed the stimulant themselves. And some preparations that we mentioned in those time releases are specifically designed to reduce the risk of misuse. So substance use and suicide risk. So there is a link between substance use and suicidal behavior in teens. Intoxication on some drugs causes an intense dysphoric or a very sad feeling, or an emotional letdown. And you can have behavioral disinhibition compounded by impaired judgment that increases risk of suicide in the context of substance abuse. So substance abuse and mental illness are closely connected. Each is caused by, worsens, and is worsened by the other. I found that quote online somewhere. I can't remember the reference, but I really like the way that's stated. And so the point is, as a psychiatrist, substance use disorders often actually onset in the adolescent years. And we are increasingly considering just maybe getting into the treatment of addictions directly ourselves. We're not quite there yet. We have subspecialists who do that within the in medicine, and we refer those kids, but there's some thought that we should integrate that treatment into our standard practices. We're kind of like on the cusp of maybe starting to do that more and more. We're just not quite there yet. So, but we do need to recognize the substance. We do need to refer. We do need to be able to talk to kids about it. We do need to reduce the chance that we are in any way, shape, or form contributing to any kind of an addiction that could be evolving. So adolescent suicides frequently involve substance use. So was there a question on the chat? I thought I saw something come up.
Yep. Have you seen young patients legitimately outgrow the need for their ADHD medications, or is it typically a lifetime prospect?
Oh, lots of times they outgrow the need for ADHD medicines. I mean, I don't know if I should say. So the literature says, the evidence is that about 2/3 of individuals who have an accurate diagnosis of ADHD, who have symptoms that are significant enough that they seek treatment, and 2/3 will continue to benefit from treatment through adulthood. That doesn't mean 2/3 stay on their treatment. Most people don't. But increasingly, more adults are being treated for ADHD, which might help explain our stimulant shortages that we're experiencing right now. Significant shortages, availability of our stimulant preparations at the moment, because more and more people are taking these medications. And so, but plenty of kids, the brain matures until about age 24. And so with ADHD being mainly involving the frontal lobe of the brain, with that brain maturation and development, and just with improved coping skills and time and practice using those coping strategies, in the case of ADHD, strategies to help uh, them to do better despite the fact that they still have ADHD, so they can get by without their medications more successfully as they mature. If they're going to college, and then in certain careers and professions, that focus is even more important. I like to remind teenagers that focus is really important when you're learning to drive a car. So please take your medicines when you're learning to drive, and while you're a new driver especially, because that's a big safety concern. So Yeah, the medication, the child gets to the age of 18, they're going to choose for themselves when we realistically, they're choosing for themselves, at any point along the way, right? Because the child has to also agree to the treatment. We can't force the treatment, but in my experience, most of the kids will continue their treatment if their parents feel that it's beneficial. They can usually see that it's beneficial, and usually treatment is continued through high school, but some kids don't need it all the way through high school. I've got a lot of patients I'm still following who are in college and getting ready to graduate, and a lot of them are still taking
My
the
son
treatment.
just graduated in December, so
Yay!
yay, I know, but he still needs the medication.
Yeah,
There was another question that came up.
yeah.
When would you move to something like ECT, particularly with a diagnosis Down syndrome regressive disorder?
Oh, I love that question. So, you're Dr. Ellerbeck, developmental pediatrician here at KU.
Nope,
Um,
she's retired.
I know. I was getting ready to say that.
Oh,
Recently
okay.
retired. So Dr. Ellerbeck and I did a grand rounds presentation on a case, young adult with Down syndrome who developed catatonia and did not respond to other treatment interventions. The diagnosis, in fact, was delayed. People didn't recognize it quickly enough. And ECT as a treatment of choice, if benzodiazepines are not effective, you start with benzodiazepines and then you move pretty quickly to ECT. That's electroconvulsive therapy. It's what is commonly known as shock therapy. Very safe when administered under controlled conditions. Um, but yes, with regressive Down syndrome, if that's catatonia, people with autism, other developmental disabilities, including Down syndrome, uh, and some other disorders. I'm blanking off the top, but there are a lot of different people who are at elevated risk for developing catatonia, and ECT is a treatment of choice. ECT or electroconvulsive therapy is also indicated in treatment-resistant depression in adults. We've had a few adolescents who needed ECT for treatment of major depression. The major depression was so bad they couldn't function. They stopped eating. They were vegetative and couldn't function whatsoever. So ECT, and it doesn't have to get to that point for an adult to utilize ECT as a treatment for major depression. It's very safe and effective. So we do ECT here for mainly for adults. And now they're doing some other kind of treatments for treatment resistant depression in adults besides ECT, but that's another whole nother topic. Does that answer that question, I think? Okay, so last slide is this, as I promised I would tell you what SBIRT is, and it's screening, brief intervention, and referral to treatment. So the Substance and Mental Health Services Administration says that this is what we need to do. Adults who interact with youth need to be aware of the signs of substance use and be aware of services in the community where you can refer kids for treatment. Be respectful of their confidentiality, and if at all possible, when dealing with adolescents, try to avoid breaking the trust. Sometimes you have to for their safety, right? But if they don't feel like they can trust a healthcare professional or any adult in a position of authority, they might be less likely to turn to adults when they need help in the future. So you need to respect their confidentiality as much as possible. Screening should be brief and relevant for adolescents and can include a motivational interviewing, which might reduce substance use and high risk behaviors. And even if the goal or the willingness of the patient is not to stop, that we might at least, they call it harm reduction, reduce the risky use until maybe they're willing and ready to quit altogether, if that's the ultimate goal. And then the treatment itself needs to be tailored to the needs of the individual, and that's true for anyone at any age, but we especially need to address co-occurring psychiatric disorders, like major depression, trauma. We need to address family concerns, and successful treatment for adolescents is generally going to involve family. very much. So if the family can't get involved in the treatment for the adolescent is much less likely to have success in treatment. So there was another question, I think, on the chat.
It was just about getting a certificate of attendance. So,
Okay.
um,
Okay.
but I do have a question, and it's back on that seizure. You had mentioned seizures with some medicine, but it was a very rare, and you thought maybe you should move it over. And you also mentioned that your counterparts in neurology didn't think you needed to scan first for
Yes.
seizures. So what if a family wanted you to, though? I mean, will neurology do that then if the family wants and requests that?
And so an electroencephalogram, an EEG, generally speaking, the neurologist will do the evaluation first and decide whether or not the EEG is indicated. I could probably place an order for an EEG directly. However, I don't work with the EEG lab. And if the child gets to the EEG and they're nervous and they need a little something to help them calm down and relax in order to allow the electrodes to be placed on their scalp in order to get the procedure done, I'm not part of their care team. And so I
Gotcha.
never order EEGs directly myself. So that
Gotcha.
means the neurologist would have to concur that it was important to do. And so usually I feel like they are if we refer to neurology and say we have a high index of suspicion. The medication was that was on the antipsychotics. Antipsychotics can lower the seizure threshold, and that means if you give an antipsychotic to a child who's vulnerable to developing seizures, but you just don't know it because they haven't had their first seizure yet, it might trigger their first seizure. So there are other medications that can do that as well, but antipsychotics are the highest risk of the meds we prescribe that can cause that to happen.
So I'm not knowledgeable in this area, obviously. When you say it could bring on their first seizure, so let's say you go and you take them off that medication, does that mean the seizures will stop?
Not
Or
usually.
do you think it is a continuation?
Yeah, so what it is, it's thought to trigger that first seizure to happen that was bound to happen anyway. It just had not onset quite
I
yet.
gotcha.
Yeah, it
I
triggered
hear what
some.
you're saying. They would have ultimately had seizures in their
Yes,
life. This is
yes,
just bringing it on quicker then. And it's
yes.
good for them to know at that point then too, in a way.
Right. And so it's a little bit similar to we've had patients who use, say, methamphetamine, and they have their first psychotic break. Well, sometimes that psychosis never resolves, and they have now all the symptoms consistent with schizophrenia. Well, we think that in most of those cases, they were predisposed to developing schizophrenia, and the drug triggered that first episode, triggered the onset. And now, instead of, it may have been a few more years before they ever had that onset, but they brought the onset on earlier
Earlier.
because of that. Yeah.
Okay.
Okay.
Yeah. I know Matthew just recently changed from a pediatrician to a adult medical provider. And it was really funny because she said when we left and, transferred that prescription of the Ritalin methylphenidate, she goes, just let them know that you've tried everything. We could probably go back and try something, but this was so old school. I know Dr. Thoreau, when she was
yes.
there at KU, that she's the one who put that medication prescription together for him because it was weird. It's so weird. I mean, even we had to find the specific manufacturer. When we were in Nashville, they changed the manufacturer at the pharmacy. And like for a week, all of a sudden I'm like, what is going on here? Like it's all of a sudden not working. And so it was really surprising to me. And they just said it's the manufacturer. They changed things. So it's wild to have to go through all these different medications to find what works. And so what I'm saying to the world right now and all parents, I feel your pain when you're going through all of those, trying all those different medications. I have been there and done that. So I can feel that pain with you.
Yeah.
Did anybody have any more questions? I don't see any more on Facebook. Did anybody here have any more questions? If not, well, we will end early. We appreciate everybody attending. Appreciate Dr. Genovese for sharing some of her time this evening and knowledge around medications. This is something I know a lot of us are interested in learning more on. You can join us next month on February 9th. We're going to have 2 attorneys from the Disability Rights Center of Kansas coming to talk to us about alternatives to guardianship. Really what I've asked them to come and discuss is the paperwork you can use versus guardianship. So I hope you all have a good night. Stay warm. All of a sudden, I woke up to snow this morning. It was crazy. Like it was 55 yesterday and this morning snow. So enjoy. Have a great evening, everyone. Thank you.
Thank you, Stephanie.